Today we are going to investigate itching, not treat it blindly. This is a step-by-step clinical approach to understanding pruritus. The goal is not to memorize diseases, but to understand how doctors think when someone presents with itching. When you approach itching logically, treatment becomes simpler, safer, and far more effective. The first and most important principle is this: itching is not a diagnosis, it is a signal. Your first job as a clinician is not to prescribe, it is to decipher what this signal actually means. Itching can originate from skin disease, stomach disease, nerve dysfunction, psychogenic cause, or external irritants. Treating the itch without understanding the source is the most common reason treatment fails. This question is the foundation of the entire evaluation. Is this a skin problem, or is the skin completely innocent? Asking this single question prevents nearly half of all diagnostic mistakes. If the skin is innocent, no cream, no matter how strong, will solve the problem. This is the fork in the road where the investigation splits. The most common physical finding is whether a primary lesion is present. If the primary lesion is present, dermatological causes dominate. If no primary lesion is present, you must immediately think beyond the skin towards systemic, metabolic, or neuropathic causes. A very common pitfall is falling at the step and endlessly changing cream when the skin is not the primary problem. History taking is not casual conversation, it is interrogation. Onset and duration provide critical clues. Acute itching over days suggests allergy, contact dermatitis, urticaria, insect bite, or scabies flare. Subacute itching over weeks point towards eczema, fungal infection, or drug reaction. Chronic itching lasting more than 6 weeks is never innocent in adults. At this stage, systemic causes must always be considered. Distribution. Where the patient is itching matters as much as what they are feeling. Localized itching usually indicates a local cause. Groin involvement suggests fungal infection or diabetes. Interdigital itching raises suspicion for scabies or fungal disease. Scalp involvement point towards seborrheic dermatitis or tinea cavitis. A single localized patch suggests lichen simplex or neuropathic itch. Generalized itching, especially without a rash, should be treated as systemic disease until proven otherwise. Now we move from questioning to observation. This is evidence analysis. The rule is simple. Look before you touch. Many visible skin changes are not the cause of itching. They are the result of scratching. Correct interpretation at this stage prevents misdiagnosis. Primary lesions cause itching. Secondary lesions are caused by scratching. Scratches, thickened skin, and dark patches do not always indicate skin disease. Mandatory search zones must always be examined, including finger webs, groin, axilla, scalp margins, nails, palms, and soles. Never rely only on the area the patient points to. If only secondary lesions are present, the itch can persist. When a primary skin lesion is present, the diagnosis is usually on the skin itself. There are five common causes that account for the majority of cases, and identifying them correctly simplifies management. Urticaria presents as transient red swelling that appear and disappear within hours. The treatment logic here is clear. Antihistamines are central. Scabies present with intense itching, often worse at night, and commonly involves close contact. Treating only the patient without treating contact and environment leads to failure. Fungal infections present with scaling and sharp margins, especially in moist body folds. Inappropriate steroid use worsens these cases. Eczema and contact dermatitis present with ill-defined oozing patches. Remove the trigger and restoring the skin barrier is essential for successful treatment. Some patients develop a self-perpetuating itch scratch cycle. Repeated scratching leads to a thickened dark skin, which in turn increases itching. Certain sites require special attention. Palms and soles without rash often indicate systemic causes. Scalp itching may indicate dandruff or fungal infection. Generalized itching should always raise suspicion for fungal disease and diabetes. This is the most dangerous category of itching. If the skin looks normal but the patient is itching, the cause is likely not in the skin. At this stage, continuing topical treatment only delays diagnosis. The investigation must go deeper. Good clinicians do not order every test for every patient. Investigations are indicated when itching is generalized and chronic, when there is no rash, when there is poor response to rational therapy, or when an elderly patient develops new onset generalized itching. A basic first line test panel includes blood sugar, LFT, thyroid function, kidney function, especially in the older adults. Management should always be logical and conservative. Focus on protecting the skin barrier, avoiding unnecessary long-term steroid use, and identifying cases that require referral. Referral is essential when itching remains unexplained, persists despite appropriate treatment, or when systemic disease is suspected. This video is intended for educational purposes only. It does not provide individual medical advice, and it is not a substitute for consultation with a qualified healthcare professional. Diagnosis and treatment can vary based on individual circumstances. Please seek professional medical care for personal health concerns. If you cannot see the cause of itching on the skin, the cause is probably not in the skin. Understanding this single principle changes how you approach itching forever.